Okay, so operative nursing, this should be hopefully a short one. So, some general tips about operative nursing is freshly post-op patients are the most acute on your floor. So you're not going to be delegating your cares for this freshly post-op patient. Um, Preoperative teaching is done before surgery and the anesthesia kicks in. So, for example, teach incentives spirometer before anesthesia and then reinforce the teaching afterwards. Informed consent is obtained by the surgeon. Nurses can be the witness signature. Before you take the patient back, you need to ensure that consent has been signed. If at any time the patient expresses doubt about the procedure or doesn't understand what they are getting done, you need to pause and call the surgeon because they need to come back and explain a little bit better. But you can always ask a general open question like, what do you know about this procedure that you're having done? Okay. In an emergency, informed consent is bypassed. It's not required, even for minors under 18 years when they're needed for emergency surgery and are not like awake. Okay. The pre-op period, you're going to interview them, get their baseline vitals and labs, so you have something to compare it with afterwards. The surgical site is marked by the doctor. Medication, history, review, culture. So if they're like Jehovah Witnesses, like they're not getting blood transfusion, if so happens during the procedure. Informed consent is one of the most important parts to make sure. Review of body systems, so like general review, make sure everything's intact, looking good. Family history, any allergies, that's super important. Teaching and medication administration. So there might be like a prophylactic antibiotic ordered for this particular surgery or whatever. You just follow the doctor's orders. Okay, pregnancy test for every female at childbearing age. Diabetics, obese people, and elderly are more at risk during surgery. Okay. Intraoperative period, make sure there's a timeout to ensure the right patient, right surgery, right site, right tools, etc. This is extremely important. Anesthesia can be given via inhalation. Just be aware of malignant hypothermia. If this happens, like there's temperature skyrocketing, skyrocketing, and all their vitals are out of whack, make sure to give dantrolene, and it's pretty large amounts of dantrolene too. So make sure, and you can also, another type of anesthesia is an IV neuromuscular blocker or medication. Conscious sedation can be minimal to moderate anesthesia, but deep sedation and analgesia and general anesthesia means you're like knocked out, you're unconscious. This requires intubation, so rapid sequence intubation, there's a kit for this. Pre-treatment is going to be lidocaine, fentanyl, atropine for secretions or vecuronium, so provider choice. Sedation, etomidate, propofol, midazolam, or ketamine. And the paralytic is succinylcholine, rocuronium, or vecuronium. Okay. Circulating nurses' role, they don't scrub in, but they're in charge of documentation, positioning. They're the patient's voice, their advocate. Do vitals, fluid, they grab needed items, insert Foley's, manage the IV, collect specimens, add medications to the sterile fields, go run and grab fluids or whatever is needed. So, post-operatively, this period is very important. Remember, they're most acute patient on your floor. You're going to be doing initially when you first get them your ABCs. Pain, nausea, vomiting. So basically, it's ABCs, then vitals, pain, nausea, vomiting. Level of consciousness, so you do your Glasgow score, check the surgical site. Remember, don't remove that dressing unless the surgeon has done it first. But when you do, you want to make sure the surgical site is well approximated. It hasn't like gone through evisceration or dehiscence. Make sure you get their EKG hooked up and do neurological checks. We want to decrease delirium, which is that temporary neurological state, like forgetfulness and like they go sort of crazy. There's a risk for aspiration, so we want to keep them NPO beforehand to decrease nausea, vomiting, atropine for the secretions, and they could have an NG tube ordered for decompression of the abdomen. Okay. Triple A, aortic abdominal aneurysm or abdominal aortic aneurysm can be determined using a FAST scan. So this is just an ultrasound and they quickly run over just to see. It's often asymptomatic, but if it's over 5.5 centimeters, it's usually going to be an open repair to prevent a rupture. So they'll just reinforce it with like a graft. The risk is that it can dissect, causing severe pain, decreased perfusion to legs, and it's potentially life-threatening. Liver resection, this could happen as a surgery, dissect part of the liver. Hemorrhage, because the liver is very vascular. It can also cause bile backup, which can then affect the lungs and blood, cause like aspiration of bile into the lungs. Spleen rupture, if the spleen is at risk for rupturing, don't palpate it. You probably will be able to feel it because it'll be enlarged, but you don't want to overpalpate it. It's the left upper quadrant. It can be referred to left shoulder pain. Obviously, people at risk for spleen rupture, they're not going to be playing like high contact sports. They're going to be pretty like mellowed out. After removal, there's a high risk for infection because the spleen is what filters and it's a huge part of our immune response. With bariatric surgeries, there's a risk for resedation because when they're obese, they hold on to like the anesthesia and their fatty adipose tissue. And also delayed healing, lack of nutrients, poor nutrition, lack of vitamins, and just more tissue that has to heal. Ambulation helps with shoulder pain. So shoulder pain is like referred pain because when any abdominal surgery goes on, like whether it's laparoscopic or whatever, they pump air into the abdomen so that they can see everything going on, and that air travels to the shoulder and causes pain there. And so ambulation is the best way to reduce that pain. Okay, couple questions. Okay, just reassess the condition of a post-op client who's admitted 1 hour ago. Plans to monitor which parameter most carefully during the next hour. 1, urine output of 20. It should be 30 mils per hour for an adult. And this is low, meaning the kidneys are not being perfused as they should be, which may indicate that cardiac output is not great. 37.6 is a normal temp. Blood pressure 114/70. Looks great. Serous drainage is expected on a surgical dressing. Okay. Ask why it's so important to deep breathe and cough after surgery. The nurse incorporates the understanding that retained pulmonary secretions in post-op client can lead to what? Pneumonia. Okay. You have a perforated gastric ulcer. They cannot sign the operative consent because of sedation from opioid analgesics. Nurse should take what appropriate action? And the answer is 4, obtain a telephone consent from a family member following agency policy. 1, obtain court order, not necessary if they have a family member. 2, have the charge nurse sign the informed consent immediately. That is not in the scope of practice of a charge nurse and is illegal. 3, send the client to surgery without consent form being signed. This is not an emergency. There is a scheduled surgery. They need consent. Okay. Okay. Anxiety about the upcoming surgery. What response by the nurse is most likely to stimulate further discussion? The answer is 3. Can you share with me what you've been told about your surgery? Just an open-ended question. 1, if it's any help, everyone is nervous. That's diminishing the patient's feelings. 2, I will be happy to explain the entire surgical procedure with you. Well, they might not need that. It might be excess information you want to find out whenever you teach someone. You want to find out what they know and then teach from there. Or let me tell you about the care you'll receive after surgery and the amount of pain you can anticipate. That'll probably just increase their anxiety, to be honest. Just wait and see what they tell you first. Okay. Pre-op teaching for a client scheduled for surgery in 1 week. Client has a history of arthritis and been taking ASAs, which is aspirin. Determines the client needs additional teaching, so which statement is wrong if they say what? The answer is 3, I need to continue to take my aspirin until the day of surgery. No, usually stop like a week or 2 beforehand to decrease the risk of bleeding. 1, 2, and 3 are correct. So, okay. So pre-admission labs, baseline labs, which should be reported to the surgeon's office, knowing that it can cause the surgery to be postponed. Sodium 141, that's normal. 135 to 145 is normal. Hemoglobin A is pretty low. So platelets 2100. I can't even say it. You know the number. It's late. That's a normal amount of platelets. Anything over 150 to 150 to 400,000 is the range. Serum creatinine, this is also normal. So that's the only abnormal one. Can be postponed because they're at a significant risk for huge blood loss. And that is it.